These are where we got the information from. So all assaults by the Queensland Police Service that were flagged on the Q Prime report with alcohol-related incident. These were all de-identified as well, which overcame a lot of barriers, as I mentioned. The MOU with the licensed venue security providers, the context in Cairns is that out of all of those venues, there's only 4 that aren't supplied by one contracted security provider. So there are a few venues who didn't capture, but with that one contracted Queensland security providers, at the end of each shift, they'd fax through their incident registers and to their head management. At the end of each month, we'd get the collated number from all of the different venues. And yeah, a major limitation to that though was that providers of security to 4 venues aren't part of that provider. And so no information was lodged through them, and also I think enthusiasm waned because no information was lodged from the security providers throughout June at all. So the next slide here, which shows the combined figures of everyone. It's just worth bearing in mind that the venue security, which is the yellow one in the bottom right-hand corner, that only includes April and May. The others were for the 3 months. And it'd be no surprise to anyone that the ones reported to police were 39 incidents out of a total of 384 all up. There's a whole lot of different things here. So these ones, for example, this was seen by both venue security and the emergency department. This incident was seen by closed circuit TV, police and the emergency department. Police, emergency department, police, CCTV stuff there. And we don't know how many incidents went unrecorded or undetected, and there's no easy way to gauge this, but we're pretty confident we got them all. Or we got most of them. We're confident we got most of them. There's no overlap between the venue security and the CCTV because the venue security were assaults that happened within the venue itself, so they wouldn't have been seen by the open space cameras. And also the emergency department, we get the de-identified ones for yes, and I'll talk more about this as well, but yes, no, or unsure were the 3 categories. For yes and unsure, we got the actual de-identified text of the presentation to the emergency department, and we went through that by hand. And we took out probably another 100 or so of things like, there was one person who'd backed over a child in a driveway. There was another one of someone who'd had a torn scrotum for 2 years and had to have it fixed at 2 a.m. Sunday morning. So I don't know how that got in there, but we're repeating this data collection process this year, so we're looking at ironing out some of these issues with that one. So through the combined data, this is just a bit of further analysis. You can see this is the days of the week the presentations happen, basically almost bimodal, Thursday night and Saturday night, and this is 24 hours, so it's midnight. Sorry, it's 1 minute past midnight Monday morning to midnight Monday night, so there's a bit of a flow over that isn't captured in this graph. And that's also no surprise, to anyone. Halfway through the study, we conducted 12 feedback sessions and focus groups with the stakeholders as well. So we were able to give them this up-to-date information, and which really helped. There was some talk about shifting some resources from Thursday night to Friday night, but we were able to give them this information, and then things changed as it went on along as well, but it was good to be able to give real-time information to agencies. And this is the number of incidents by the time of day. This little bump here is probably, you can see most of that's the emergency department. So that's presentations, we're guessing, that happen mid-morning. Someone wakes up and sort of, how come I've got no teeth? And head off to the emergency department. And then there's a steady climb from about 7 p.m. and based on interview results, people would say there's 2 shifts of drinkers. One, people start drinking straight after work and they continue on, then about 11 o'clock they go home. Then there's the nightclub goers or the late night entertainment precinct goers, and they continue to climb. They climb on. These 2 right over here, these are the obvious peaks. Lockout occurs in here, so it's an hour before and an hour after lockout, which happens there. That's when the assaults are happening, which is also, interestingly, at another focus group leading up to New Year's Day, the district inspector said to the chair of the Licensees Association, he just said something about preparing for New Year's Day. They do a lot of preparation and event management preparation. And he said, you know, well, you guys never have any problems on New Year's Day either. And the president of the Licensees Association, just in a flippant aside, said, yeah, that's because there's no lockout. And we just moved on. So that was a really interesting finding. Excellent. Yeah, so around lockout and midnight, there are times with a lot of movement on the streets, so that's when that friction occurs. So comparing these with the green ones particularly, which are the emergency department ones, with a study that happened in parallel with two doctors, Doctors Deb Maher and Cheryl Bird, who are registrars in the emergency department. At the same time we were doing this, they collected data on all chart presentations for alcohol-related assault that presented over a 6-month period to the Cairns-based hospital. So from the 1st of July to 31st of December 2009. That was extremely labour intensive for them. They went through all patient presentation records, pulled out ones that had an alcohol ETOH flag or certain ICD injury codes, ICD-10 injury codes. Then they went by hand through every chart that was flagged through that process. That took them a couple of months to do that. So the difference in the labour intensity between those two, working on that and ours, basically to set up the data collection mechanisms for ours, apart from the venue security providers, it took, and the workshop, which was to get everyone's agreement together, to actually set up the data, the report builders, took less than 5 hours for the emergency department and the police, and then took virtually no time at all to get the information through to us. So that was interesting. I think I'll talk about that a bit more later on. But compare that with, you know, I don't know, 70, 80 hours each that the two doctors did doing the retrospective chart analysis, and the accuracy also isn't there. So there were 548 cases, which were also essentially across from the Cairns Regional Council area, but 43% of these assaults were in males aged under 35. This is where they happened, and again, data is very limited within the charts because it's not the focus of the emergency department to see where this assault occurred. So specific information about the precise location is very limited in hospital records and has little or no clinical relevance, obviously. But from a crime prevention, a public health and a community benefit perspective, it is vital information. So from the limited information available, of which there was only enough information out of those 548, just over 200, most assaults occur in the Cairns suburbs, but the CBD does represent a sizable proportion of the overall burden. And in only 55 presentations was there any information about whether they occurred in the CBD or not. So determining the location where an assault occurred was a key priority for our study. And where they occurred this is still the retrospective chart analysis. Around 60 occurred in a bar and hotel, other public locations, so that can also include the City Place, which is near the taxi rank, and also the nighttime esplanade, and some other areas that are used at night. Private location and institution, which is either the emergency department or the watch house, basically. There's a couple of other places. Also, interestingly, from this study that Deb Maher and Cheryl Bird did, 75% were Cairns residents, which surprised a lot of people as well, because we've got such a high tourist population. People thought there'd be much more tourists, and in fact the interviews said that a number of the assaults that were occurring were UK people, basically. So there was a lot of problems with UK people, but that wasn't borne out by the data. That's a perceptual sort of thing. So 75% were Cairns residents, and 75% had a previous presentation to the emergency department for either an assault incident, an assault-related presentation, or an alcohol-related presentation. And yeah, women tend to be assaulted more in public places and private locations, not in the bars and hotels. And that's also not a surprise. So this is the Cairns-based emergency department hospital. It's just been redone, and it's a very good facility at the moment, or from now on. But we did think that 55 assaults in the CBD over 6 months was an extremely low and wasn't consistent with police data for one thing. So our prospective data collection tried to improve the count. The process that we used with the emergency department was basically we held a number of information sessions with ED staff, both nurses and doctors. We got a champion going on. The nurse unit manager is very keen on this sort of stuff, on reducing the workload for his staff, reducing the associated problems for his staff, reducing assaults on his staff, and generally looking after, you know, the health of people who present to the emergency department there. So he was our first champion, and we rang him up and said we're working on this study, and he said, well, come in. So we went in that afternoon. He took hold of it, told us we had to talk to the emergency department information system data manager and get the approval of the director of ED, and then he helped champion it all the way through, organised for the nurse unit educator to organise the interviews. So we conducted 6 interviews with nurses as well, and gave us that link to the doctors because there's the 2 medical staff focus. So yep, through consultations with it's called the EDIS, the Emergency Department Information System, the data manager linked a software project to the EDIS system to de-identify any presentations by patients. So that was a major hurdle that was, through their knowledge, was quickly overcome. And during the months of April, May and June, we asked triage nurses to type CBD in the presenting problems text if they had reason to believe the incident occurred in the CBD, and at diagnosis a compulsory drop-down screen came up for doctors for some ICD-10 injury categories and some alcohol codes. They triggered that compulsory question, which was, do you have any reason to believe that this presentation is the result of an alcohol-related assault in the CBD? So for cases with the CBD flag and with the yes and unsure, we were provided with the text of each presentation and went through it as I sort of described. Some stuff with this was, it took less than a second for the doctors to fill in, but it came in at the same time a whole password system was being generated for the EDIS. So there were 2 incidents over those 3 months, at the beginning of those 3 months basically, where there were calls at night from doctors saying, you know, it wants a password for me to fill this thing out. And so there was a bit of frustration on those 2 occasions. That was an entire EDIS password thing happening, but it was attributed in some ways to our project as well. But apart from that, one of the feedback sessions, where we specifically asked the doctors about it, was that it took no time at all to fill in, and it was no resource impost on them at all. So the information sessions we conducted, we put up maps and also talked and listened to what the emergency department staff had to say, and we explained, you know, this is the area that it happened, that we're interested in. So yeah, that ongoing information stuff and involving people, and I really think helping to get a perspective of why it would be helpful to the emergency department overcame a lot of barriers or potential barriers. We did a couple of observational sessions in there as well. So midnight, till 3 a.m. on Friday, or 11 till 3 a.m. on Saturday, and the fact that they saw us in there and we were able to talk and listen to them also contributed to that, I think. And the fact is, I saw them save one person's life in there. That's always going to be their priority. So research it's a longer term sort of view, and not everyone there, people who save lives, that's their focus. So this research stuff is still quite nebulous and abstract to them.